Hi, my name is Helene Chesnais. I'm a third-year medical student at the Perelman School of Medicine here at Penn. Today, I'll be presenting on drug-resistant epilepsy and its evolving treatments in the field of connectomics and neurostimulation. The International League Against Epilepsy defines drug-resistant epilepsy as failure of at least two appropriately chosen and tolerated anti-epileptic drugs. The two drugs may be used as monotherapies or in combination, and they need to fail to control seizures adequately. It is estimated that 25 to 40% of people with epilepsy will continue to have seizures despite treatment and will fall in this drug-resistant epilepsy category. The underlying causes of drug-resistant epilepsy can vary widely, can be caused by structural brain abnormalities, genetic predispositions, developmental disorders, brain injuries, tumors, infections, or a combination of these factors. The diagnosis is usually based on a detailed medical history, including seizure type and frequency, as well as imaging studies such as MRI, CAT scans, and EEG recordings. Treatment options include surgical resection of the epileptic focus, and surgery is often considered if the focus is localized and well-defined. Another option is vagus nerve stimulation, which involves implanting a device that simulates the vagus nerve to help reduce seizure frequency and severity. In children, the ketogenic diet, which is high-fat, low-carb, has also shown some efficacy in reducing seizure burden in some DRE cases. Managing DRE is quite challenging due to the unpredictable nature of the seizures and the limited treatment options available. Seizures can have a significant impact on quality of life, and another challenge is that responses to different treatments vary greatly among individuals. Therefore, finding the right treatment approach requires a personalized and multidisciplinary team of neurologists, neurosurgeons, and other specialists. I wanted to give a case study on resective surgery for epilepsy, because while it often is effective in reducing or eliminating seizures, it is not without its potential downsides and risks. In this case study out of a French hospital, we have a 57-year-old female patient with drug-resistant left mesial temporal lobe epilepsy. Her MRI revealed a cavernoma between the amygdala and the anterior part of the parahippocampal gyrus. She underwent left anterior temporal resection, sparing the hippocampus, and 2 years later she was seizure-free, but she did have a significant verbal memory impairment. And interestingly, because she was a waitress, this verbal memory impairment significantly affected her quality of life, and she was unable to remember the orders of her customers. The authors proposed a rehab program that was focused on nonverbal memory, which had been preserved in the right mesiotemporal lesion, given that she had the left one removed. And essentially, she had to try to picture the customer's orders rather than remembering the associated names. Her verbal memory did recover, and at least moderately, and she did have an improved quality of life, but I do think this case illustrates the potential severe consequences of having this life-altering surgery and the fact that these changes may sometimes be irreversible or at least hard to recover from. Because of this, over recent years, experts have called for a new understanding of epilepsy, which could harbor newer and better treatment options that would not be as potentially debilitating as resective surgery. Advances in neuroimaging, genetics, and neuroscience have continued to shed light on the complex nature of epilepsy and potential treatment avenues. The most exciting of these advances, and what I'm going to talk about today, is the application of connectomics, the science of networks, to the epileptic brain. So why does this matter? Take the case of temporal lobe epilepsy, for example, which stands as one of the most common examples of epilepsy that is generated from a focal onset. So it's a focal onset seizure, which then propagates by the hippocampus to involve the entire cortex. There is emerging evidence that shows that there are actually structural and functional irregularities on both sides of the brain in individuals with TLE, which prompts a conceptual shift of viewing TLE as a complex network disorder and not just a focal onset disorder. So some basics on neuromodulation, just so that we all have the same vocabulary while we consider this topic. First, what is a network? It is a group of interconnected entities of nodes. So the nodes can be connected via edges or connections. The seizure onset zone is the brain region or network that is responsible for the development of seizures. And synchrony is a very important topic that describes if networks are functionally connected and if they correlate on EEG, if their activity correlates on EEG. This is an image from a study by Shaw et al. that was published in 2019, where they created a model of what the EEG looks like before and after surgery. And they found that in patients with good outcome following resective surgery, the zones that were excised from the brain actually demonstrated very high connectivity. So the green here shows you the zones that were resected, and the darker blue shows you where the networks were most connected. In individuals with poor outcome following resective surgery, the zones that were highly synchronous were not excised. So why do we need to consider epilepsy as a network model? Newer evidence suggests that several networks interact with one another, and these networks are recruited or disengaged during an epileptic attack. Which sets are engaged or disengaged determines the seizure phenotype and the response to treatments, but it may also explain the interictal behavior, the behavior between seizures. There has been some evidence that the interactions between networks may be abnormal, even between seizures, which leads to the idea that epilepsy should be considered to be always quote unquote on, and not only exist when the patient is seizing. When we view epilepsy as a network disorder, we may access a better model of epilepsy's functional abnormality, both during and between seizures. In addition, we may uncover new multimodal treatment strategies if we consider this network approach. The treatments would aim to restore physiological network interaction, both between and during seizures. And two examples of the newer treatment strategies that I'm going to talk about are responsive neurostimulation and deep brain stimulation. In responsive neurostimulation, or RNS for short, there is a device that's implanted into the brain to monitor neural activity and deliver targeted stimulation to disrupt the seizure onset. So you can see on this image on the right that the probe is inserted right at the seizure onset zone, the SOZ, and the probe will sense if a seizure is generated and will deliver a shock in response. In deep brain stimulation, or DBS for short, instead, the target is one of the influential downstream propagation points within the epileptogenic network. The DBS probe actually prevents the onwards part of seizure activity, either via direct inhibition or via disruption of the pathological activity of these circuits. These two mechanisms of actions are known as functional lesioning, so just completely inhibiting the seizure, or jamming theory, which is when the networks themselves are disrupted. Essentially, you're either shutting down the abnormal network connections or you're jamming them. Intracranial EEG, fMRI, clinical observations, and anatomical studies have elucidated some of the networks that we can target with RNS or DBS. This is a wonderful image from the Piper et al. Paper that was published in Brain 2022, which most of this talk is actually based on. And they demonstrated that the two common targets of brain stimulation are the anterior nucleus of the thalamus, which has connections to the Pepez circuit and is mostly involved in focal onset seizures that then spread to the cortex, and the centromedian nucleus of the thalamus, which itself has connections to the SDN, this subthalamic nucleus, and the cortex. And it has been involved in Lennox-Gastaut as an important target for brain stimulation. So the benefit of these therapies that I've talked about is that they provide a greater degree of control and reversibility while being minimally invasive. Another advantage is that they offer accurate and controllable treatments. But how do they work? RNS is believed to suppress synchronization locally or regionally during the occurrence of epileptiform activity. And as for DBS, studies have suggested that it disrupts pathological oscillations as a therapeutic mechanism. It may prevent propagation points such as the thalamus from allowing seizure activity to propagate and to synchronize with the unaffected networks of the brain. So it really seems that the ability to reduce synchronization of the epileptogenic networks in the brain is one of the key mechanisms of actions of RNS and DBS. And with further stimulation, it's possible that there may actually be induction of plasticity in the brain. So the idea would be that neurostimulation would normalize brain networks after repeated stimulation. This would ultimately reduce the number of focal onset seizures. How do we apply neurostimulation concepts to patient care? The Piper review from Brain 2022, which I've been talking about extensively in this talk, had 3 ideas for future directions. And these 3 goals happen in sequential order. The first is a pre-surgical goal, where the idea would be to isolate the individual's unique network and identify key locations that are responsible for generating the seizures. The second goal is to use preoperative data that we've just talked about to identify what the optimal stimulation targets would be and see if the outcome is actually the desired outcome of reducing seizure burden. There is one interesting study that's also been done out of Penn with the lead author of Kinney that was published in 2019, where they created this model to virtually resect nodes from the epileptic network and see if virtually resecting those nodes led to a better surgical outcome. So I will now present 2 figures from that paper. Essentially, they created a connectivity network where they saw how the nodes were connected via EEG and if they were synchronous. And then they collected baseline synchronizability of these different nodes and then tried to remove certain nodes from the network to actually see if the seizure burden could decrease. They used synchronizability essentially as a proxy for seizure burden. We can see in this figure that in a patient with good outcomes following surgery, the epileptogenic networks were actually less synchronizable with further stimulation. And compare that with the poor outcome patient, where you can tell that the networks are actually quite synchronizable, or the activity in different leads is matching up quite nicely. And this predicted a poor outcome in the patient. To go back to the third goal, the author suggests that after the surgery, we should validate the model's predictions and see if we can use that network data to predict the surgical outcome. In my talk, I've been over the fundamental concept that neurostimulation can target specific neural networks and brain regions that have been involved in seizures, and that this can be a promising avenue for treatment of drug-resistant epilepsy. Future directions will involve greater personalization of these treatment strategies and will most likely include multidisciplinary approaches. I would like to give special thanks to Dr. Stephen Brem of the Department of Neurosurgery here at Penn for his guidance throughout these 2 weeks spent in the Department of Neurosurgery. And I would also like to thank Dr. Cahigas for inspiring me on this topic of epilepsy and being so kind with his teaching. These are my references. Thank you so much for listening to my talk, and I hope you have a wonderful day.